we're very pleased to be here. A couple of comments before we start. And first of all, when Blair and I looked at the list of speakers today, we said, well, pretty strong list of illustrious speakers. So we are the local talent. And using the hockey analogy, local talent means role player and character players. So, John, we will make the best of the 8 minutes of ice time that we have today. A couple of other things. Blair and I actually come from different paths. Blair's a maritimer, a proud maritimer, and I'm a proud French Canadian. Blair is a interventional cardiologist. I'm a pediatric emergency physician. We both still practice, despite our administrative leadership role. And we feel very much at home in Alberta. I've been here for 20 years. And I don't know if that defines me as being an Albertan, but I certainly feel part of the fabric and the community, and I think Blair feels the same way. And we've benefited from a very high quality of life and the opportunity in Alberta. And certainly when I came in, came in as a clinical pediatric emergency physician, and it's been quite a journey personally and also from a learning perspective, so great learning experience. Last thing is that you'll perceive that we're quite passionate about improving health outcomes. We believe that the path to transforming healthcare and system sustainability is really with a significant focus or a unique focus on improving health outcomes. And this is what we're going to use today in terms of showing you where we are right now in our journey in Alberta Health Services in terms of improving health outcomes. Not quite there yet, but we believe that we're now at a stage where we can make a real difference as a provincial health service delivery. So who we are, and a lot of you in the audience will know this, but Alberta Health Services was created in 2008, I believe, and 9 regional health authorities, 3 agencies were merged together, and we've had to deal with a number of foundational issues over the past 8 years, but we're quite big. Over 100,000 employees, over 9,000 physicians, $14 billion of healthcare. We have over 100 acute care facilities that we're accountable for. You look at our total hospital days, 2.81 million. You can picture and read what's involved in terms of healthcare service delivery. Not only we have acute care, but we have also accountabilities in continuing care, long-term care, supportive living, home care, etc. We have accountabilities in addiction, mental health. We have some accountabilities in public health and primary care. However, I think it's really important to note that we are not a fully integrated system. Most of primary care is outside Alberta Health Services, and a good part of public health is also outside of Alberta Health Services and other community services. Most of our physicians are not employees. Less than 2% of our physicians are employees. Most of our physicians are independent contractors. So that set a little bit the stage in terms of the discussion moving forward. In terms of how we want to improve health outcomes and transform the system and really improve value, I'm going to present sort of 5 or 6 slides that really sort of outline from what I speak of as a burning platform. We're at a stage in Alberta where, as mentioned by our Deputy Minister, healthcare costs have skyrocketed. That is the line that you see climbing up. However, our non-renewable resource revenue is dropping. This is not something that's going to be resolvable anytime soon. Therefore, the need for us to find better ways to give higher quality at a lower cost. Where is Alberta compared to the rest of the provinces in Canada in terms of our per capita provincial government health expenditures? We're number 1. We are the most expensive system in Canada, not by a small margin, by a very strong margin. How's our quality? This is the Commonwealth Report ranking. Reinhardt mentioned on some of his slides. We don't do well. We are at the end of the pile in terms of our quality in Canada, in terms of access, efficiency, equity, health issues. How are we doing in Alberta versus other provinces? Really expensive, yes, our outcomes are average at best. We are leading in a few areas, but for the amount of dollars that we spent, we should be a lot better. Where are we in terms of where we spend the money? I love the slides because it highlights where we spend most of our dollars in terms of acute care, in people that are older. We have a great system, but the system was built in the 1960s. The system was built to deal with acute care, people dying, emergencies. Wasn't dealt with dealing with the problems of today. Problems of today are very different. We have now increasing incidence of chronic disease. People are living longer. One of my areas of responsibility is Cancer Control Alberta. Cancer is almost being a chronic disease as we speak. We have an aging population. With our aging population, with people living with chronic disease much longer, the needs of the population has changed totally, and yet our system hasn't, which is why we need the transformation moving forward. Patients are telling us. We've done a fair bit of progress in involving patients into what we do in Alberta Health Services. For example, we now have patients as part of our safety reviews, just as one example. There are multiple others. But they're telling us, you need to change. They're telling us you need more empathy. We need more empathy from our workers. We need more empathy from our physicians, our clinicians. Well, there's great workers in the healthcare system. I think Andrea's brought some great example that really resonated with me in terms of that. Empathy doesn't cost any dollars, but empathy is demonstrated by behaviors. We need a healthcare system that has the information flow following where the patient is. The patients are telling us, we need the technology to support what we do, to follow us. We have a patient, Maya, who's a 21-year-old, who is diabetic, had a stroke at age 6, and has to take the bus, public transit, 45 minutes, to get a 5-minute report on some of his lab tests with the nurse practitioner. So we have to get around in terms of what the patients are asking us to do in terms of health information. Health information has to follow where the patient goes. The patients are asking us to be co-designers. They want to be part of the design of the system. In Canada and in Alberta, no different than any other province, we focus on the provider-based system. Therefore, the need to change. We know that the success in moving forward is co-designing system. I think the patients understand, or the users of the system understand that it can be fully patient-directed, but when we design the system, we have to keep our eye on the patient in terms of how they see the system moving forward and what they see as value and non-value elements. So, we have the burning platform. It's time for a shift. We have to focus less on illness, more on wellness, less on what I call an administrative culture, more on an outcomes leadership, less on acute care, more on community care, and less from a single provider perspective and more for team care. I love this article because it does highlight to me, this was a Richard Boomer presented this article in August 2016. It was actually sent to me by one of our medical leaders, Mark Jaffe, who is our medical director for infection prevention and control. But I love the article because it does provide clearly what are the essential elements of system transformation and how we can actually move the system forward toward better health outcomes, better sustainability. We need relentless, clear vision through our senior leadership commitment. You need relentless leadership commitment to make things better and to move in the directions of improving health outcomes. We need an effective governance structure that sets the priorities, takes care of the barriers, and integrates multiple teams. We need team-based design teams that are away from the boardroom and that are giving the ability to improve at the local level, the bottom-up approach. We need the systems to support from an education perspective, from an analytics perspective. So you can read the rest, but I thought that if we can actually achieve those 7 essential elements, we'll be successful. So how do we move from here? We believe that we actually quite a bit of strength. We believe that being a provincial health service organization is a strength. It actually enables us to scale more rapidly, enables us to deal with issues of equity, enables us to reduce variation, and should do that. We have 4 foundational strategies: patient-first strategy, people-first strategy, IMIT strategy, and research, analytics, and innovation strategy that should help us. We have a heavy focus on quadruple aim. Our strategic clinical networks, which is really an engine of innovation and best practice, Blair will mention some of the activity there, are a real strength to us. We are now starting to get real robust analytical capacity. You know, I asked our analytics group a few years ago looking at, okay, what are the high cost, high volume, high variation conditions in the province? And we were able to actually find out that COPD, congestive heart failure, depression were actually those conditions. And we could actually map at which sites, which zones, and almost to the level of the unit in terms of the variation and in terms of the volumes and in terms of from an analytic perspective. So we are getting there in terms of analytical capacity. We have enough provincial structure and resources to support improvement in health outcomes. It is how we align those resources that becomes clear and how do we distribute them. We have zone-based quality structures that are now very strong. We have a model of collaborative care that we move forward in COAC. We still have a lot of progress to do in clinician engagement. We have implemented a dyad structure to facilitate that, involving independent practitioners and clinicians and ensuring that they're feeling part of the process is a journey. However, I know that we have improved our response rate in terms of our last people survey and, you know, slowly making progress. And we are getting better analytics in terms of how we do from a quality and cost perspective. One of our key platforms is really how do we educate and train people from a lean perspective, a Six Sigma perspective. We have developed our own in-house program, education program, AHS Improvement Way, and you know, you can get different levels of training, either at the basic level, intermediate, or even at the expert level. And I think that's one of the ways we can build capacity, but also improve the culture at the local level, the outcome improvement culture that we want to develop. So one of the, and Andreas actually spoke to this, is we have a polarity to manage. So after a lot of thought about this and discussion with folks, the polarity is polarity, first of all, is, undefined. There's no endpoints. A polarity is never resolvable. A polarity is not about one or the other. It's one and the other and how you align that symbiotic relationship. We know that we have the ability to drive things provincially, top down. We know that we need to put some focus into and prioritization in terms of activities. However, you will never be able to successful to enact change until you develop that local culture, local improvement, local quality culture. Leslie is here. Accreditation Canada told us, we are seeing some great work in terms of what you're doing in quality, but we're not seeing that local culture being established consistently. So we need to find the right balance between driving some a COPD pathway provincially or a congestive heart failure provincially, but really develop that local quality literacy, really support that team locally in terms of moving quality or health outcomes forward. We have our 4th strategy, as you spoke, but we believe that the backdrop of how we're going to move forward with making a big dent in health outcomes and system sustainability is by really using the quadruple aim. And by really focusing on our population health, identifying the goals that we want for a particular population, identifying the targets, identifying the actions, taking into consideration that we have to do this from the eye of the patient, ensuring that our care team is well cared of, that there is joy at work. We know from our experience and from talking to different healthcare organizations that a lot of the focus now is on their staff, their physician, because they know that has a direct impact on patient outcomes. And we also need to do this with, higher quality and reduces costs. So this has, here, I'll put these slides. So our focus, I think, moving forward will be, as mentioned, on our local folks, our quality councils that are at the level of the units, the sites, our zones, which are our operational units. Local councils includes people that are interested in quality, clinicians, operational folks. And we need to build around those quality councils, we need to build an improvement support team. a consistent improvement support team. Quality resources, analytic resources, financial resources, change management resources in order for us to be successful. This is the bottom-up approach that we seek. We want that local zone, site, unit improvement team, quality council to have a simpler relationship with the priorities of the organization. We understand at this point in time that they feel a bit overwhelmed because they're getting multiple inputs in terms of what they need to do. Blair has a certain number of SCN projects, quality has a certain number of projects, analytics has a number of projects. So we're going to use a quality safety executive committee to bring all the relevant stakeholders and have those strategic discussions. And then we'll use what we call a resourcing coalition to try to resolve the day-to-day issues, the barriers, define the improvement teams and move that forward. So this is a strategy that I think we think we can really move forward in moving forward using the quadruple aim and towards improving health outcomes. I always like to define, what does a future state looks like? Well, so future state for me would mean a change in culture and change of our approach in terms of how we think about the healthcare system. We need to focus on key population health targets. That would be a key success elements in terms of the future state. Commit to health outcomes improvement across the continuum, the leadership component. Fewer initiatives, more impactful. We'll need to focus, we'll need to have to make some tough decisions. Align improvement work with health outcomes. Mention about aligning the improvement team or sustainable improvement team with our quality council. Improve quality literacy at a local level and through the organization. Sustain improvement with a support team. Enhance value. We do have to focus on higher quality at a lower cost. This is how we're going to improve the system overall and be able to sustain the system over time. And finally, the issue of measure. We are embarking in the development of a single AHS, Clinical Information System. It's a huge endeavor, but will be a huge enabler in terms of improving health outcomes, bringing best practice forward to clinicians and teams, and be able to actually get the data back to them and how they're doing, and also the ability for us to look at secondary data, population data, and see how we can do things better. I'm now going to move to ask Blair to discuss a little bit the experience that we've had with strategic clinical networks, which I think is a really important driver in how we want to move forward, and then we'll close with a little bit of more focus on clinical appropriateness.
Thank you very much, Francois. I do actually think I probably have one of the best jobs in Alberta Health Services. It's not an easy time. We're facing some fiscal challenges, and I want to call out many of my strategic clinical network colleagues who are here, particularly senior medical directors. I was the inaugural senior medical director for cardiovascular health and stroke, and then rose into this role. But, having like-minded physicians who 50% of the time are still at the coalface, treating patients, recognizing system problems firsthand, but 50% of the time they're dedicated to improving this system and achieving the high-performing healthcare system that we all aspire to. So why networks? I think many of you in this room are already convinced, but just to remind ourselves what's different, what we have that we think is unique in Alberta Health Services with these strategic clinical networks. Are networks unique to Alberta? No, they certainly are not. They're used elsewhere in the UK, in Australia, New Zealand, certainly in the Commonwealth. There's a history of this. And basically, networks are a way in a non-hierarchical fashion to bring people together to brainstorm. And we create these guiding coalitions. We call them core committees that represent the front line, that represent administration, that represent policymakers from Alberta Health, Ministry of Health, to get that public health perspective, that come together to become engines of innovation, knowledge translation, joint decision making, and committed to improving the outcomes for our patients. We use clinical experience, we use knowledge and research to reduce variation. We mine ruthlessly for unwarranted clinical practice variation and improve the quality of care across our all 6 dimensions of quality. We have evolved into an honest broker for the province instead of hiring expensive KPMG consultants. Our senior medical directors actually are an incredible resource to answer questions, health technology assessment questions, whether we should put another cath lab in the province, et cetera, et cetera. We come pretty cheap, actually. And it certainly is a positive way for all partners in the system, and that's the key about the networks, is bringing partners, like-minded partners together within Alberta Health Services and, importantly, outside of Alberta Health Services, because remember, primary care is delivered largely by private practitioners, publicly funded outside of Alberta Health Services, but an incredible amount of care occurs there, so we have to partner with them. And innovation is key. We can't keep doing the same things the same way, or we'll never improve the status quo. One of the things, again, that's important in taking advantage and leveraging the One Health system we call Alberta Health Services is spreading and scaling the ideas, the pilots that have worked in certain areas of the province. And the other powerhouse that we have is incorporating research. Each of these strategic clinical networks that I'll describe in a moment have a scientific director, an associate scientific director, which allows us to harness the incredible faculties that we have in the province, not just medicine, but beyond other health professions, business, other enterprises that we think are going to improve the healthcare system in toto. These are the current strategic clinical networks. We're still fairly young. We started in 2012 with the first 6, not surprisingly organized around the major disease burdens of our time or population and demographic challenges such as the seniors' health issue, going through some of our important operational areas across the province, critical care, emergency surgery, and then evolving respiratory health. Given an industrial population, we have a lot of problems with asthma, COPD in this province. We actually still have a baby boom. We have about 50 to 55,000 new Albertans are born every year in this province. So we have a baby boom that we still have to be concerned about. Unlike many other jurisdictions in this country and even elsewhere in the world, we've been joined by kidney, digestive health, and very importantly, by public population and Indigenous health. We have Indigenous peoples of this province are one of the rapidly growing populations, have tremendous health burdens that we need to deal with and focus. So having this network join us is incredibly important. We look forward to one that's been missing all along, which is primary health care. That's a little bit different because while we interact a lot with primary care, it's not directly part of Alberta Health Services. So we look forward to joining us very soon, a primary healthcare integration network as well. These are the 3 priorities as we've come to be organized. I'm going to give you some examples of some of the successes that we've had as well. But as we look to the future, our primary focus, the promised land, if you will, is definitely transforming this into a highly performing healthcare system, looking at some of the metrics that Reinhard shared with us and trying to achieve those in Alberta. But outcomes improvement, working with Francois and Lynette in our quality healthcare portfolio. We believe clinical pathways, standardization of care, looking for unwarranted practice variation that Andreas talked to us about. Appropriateness is important. We have fiscal challenges. We've met them in the past by essentially rationing access to our services. We've got to do things differently. Let's practice rationally rather than ration. That's sort of our mantra around the appropriateness, and Francois is going to talk again about that. And that important health and social system integration. We're not there yet, but we define the role, the remit of each of the SCNs as looking at social determinants through prevention, through acute care, transition and integration back into chronic care management, and finally into palliative and end-of-life care. And that's on a foundation of innovation and research. Chris Trimble, I met him. He's an interesting cat. He's actually a former nuclear sub-commander in the U.S. Navy, but he currently teaches at the Dartmouth School of Public Health. And he introduced this concept, and it really is what we're trying to do with strategic clinical networks. So if you look at this slide, look along the cost axis versus outcomes. If we look at the tremendous advantages of biomedical research over the last half of the last century and into this one, tremendous stride mid and even 3/4 of the way through. And I show this little cheap pill or device. Well, I actually was a cardiologist when aspirin was invented. Pennies a day, 50% mortality reduction in acute coronary syndromes. There ain't any aspirins anymore. Everything we do is incredibly expensive, and the relative gain is much less, and it costs a lot more. And we're really starting to hit that wall, the sustainability wall, that unless we change things, we're not going to be able to afford these new advances. So how do we pull that cost curve down and that outcomes curves up? That's about innovation. That's why we need innovation. That's why Dr. Naylor and colleagues wrote such a tremendous report on how important innovation was in the Canadian healthcare system. And this is really, again, attributed to Chris Trimble, a really simple innovation map. What's the difference between innovation and quality improvement? They're really along a continuum. And quality is everybody's job. But, you know, everybody's job, you've got a lot of things, patient to see down the hall, et cetera. We're organized into local teams at the unit, at the site, into zones and provincial teams. Really the difference is quality is everybody's job, but having small, dedicated teams directed at certain major issues of our time allow you to shift towards more innovative thinking, using people in different ways, different people in different ways, changing the process and the way that we do things, and hopefully tips us towards finding those savings, finding those dollars that we can reinvest in other areas of the system in a zero-sum game system where we're not, as Francois showed our burning platform, we're not getting money, more money as we have in the past. And really, this applies to every jurisdiction in the Western world. So that's what SCNs are about, is trying to develop those small, dedicated teams that can look at specific issues, change the way that we do it, and produce those cost savings that will overall help the system. So we do that using data. When we launch a new SCN, we say, don't boil the ocean. You can't boil the ocean. You have to pick your battles that you think you can win. So identify those opportunities. Use data to do that. Use patients to provide input. Patients are critical on these core committees and families to identify the opportunities and challenges in their system. Co-determine those with our operational colleagues who are at the coalface managing our operation day to day. Co-develop business cases that go up through the line, and then ultimately co-deliver solutions, innovative solutions that produce better value and better outcomes for our system. Many of the SCN initiatives have really covered the gamut, certainly improvement of outcomes, not surprisingly, but not just outcomes in acute care. And I'll give some examples outside of our acute care sector. Wellness and prevention, we're not doing our job unless we think about how we prevent illness and how we prevent recurrent illness. Appropriateness and sustainability and value for healthcare, obviously another, and skilling up our provider teams and reducing variation in competencies around our provider team also has been another theme of our SCNs. I'm just going to cover a couple of these, highlight some of what not just me, but others have considered to be really home runs for our strategic clinical network. So appropriate use of antipsychotics. So when we launched the SCNs, the 6, 10 projects were funded, actually went through an extensive prioritization process, a dragon's den where people like Andreas Lapakis shot holes in these proposals. And we challenged every network to come up with a reassessment project. In other words, you know, try to find value. So we got cardiology, we failed. Who did it? Seniors and addiction mental health came up with this use of antipsychotics as a medical restraint in long-term care homes. They found a pilot in Manitoba. That's a good idea. Why don't we try tools? Found 11 adopter sites in the province. At the time, our province had high variability, but roughly about a 30% average or greater use of antipsychotics in long-term care. care. Use these tools, remarkable improvement. I mean, testimonies from, families saying, thank you for giving me my mother or my father back, just dramatic. And over the course of about 18 months, blink of an eye in a healthcare system, spread to the rest of the long-term care, about 250 institutions, 14,000 beds. We are now the best in the country, below 20% utilization. So from above 30% to below 20% and providing amazing improvement in quality of care. Enhanced recovery after surgery, amazing story done elsewhere, really a Scandinavian concept. As a cardiologist, I didn't know there was this much science in surgery. Apparently there is, but feeding patients carb loading before surgery to prevent the problems with insulin, not fluid loading them with 4 liters of salt solution after their surgery, predicting and preventing nausea and vomiting, getting patients eating after surgery, mobilizing them quickly. So starting with colorectal surgery, 2 early adopter sites, then spreading across 4 other centers, basically amazing reductions in length of stay, amazing improvement in recovery time, reduction in complications. So we're getting these patients out of hospital are actually not coming back. If they do come back, they don't have to stay as long because they're not as sick. And now we've spread and scaled that to not only colorectal surgery, but other surgeries. And in fact, several of our surgical leaders in this province now are world leaders in ERAS in other surgical disciplines. So again, we don't have to follow, we can certainly lead. The other project that I'm particularly proud of, because I was part of it, the Stroke Action Plan, we, as a core committee, when we first met, we looked at stroke mortality rates in this province. And actually, Calgary has the best 30-day stroke mortality rates, has for some time. Edmonton is not far behind. But our other areas of Alberta were lagging significantly, with up to twice the variation. That's not fair. One of our mandates as SCNs is equity in outcomes. And so what's the difference? It's things called stroke units. We had 3 in the province at the University of Alberta Hospital, at Grey Nuns Hospital here in Edmonton, and Foothills Medical Center that provide that skilled nursing care, follow the guidelines, and the rest of the hospital just admitted their stroke patients to a medical ward. Well, how can we bring stroke unit equivalent care to those medical wards? And that's what it was about. It was about having clinical champions go out to those sites. It was about developing a balanced scorecard, co-developed with the site as best practices. When do you start feeding patients? When do you mobilize the patient? How much physiotherapy do they need? In the medium-sized cities, actually having an early supported discharge where the same physio, same OT who saw you in hospital followed you to your home and actually gave you home physiotherapy. And how novel is that? There's the actual stairs that I got to climb, not some artificial ones in a hospital. Again, some amazing stories, decreased length of stay and decreased mortality. So again, moving some very large dial metrics, small dedicated teams, innovating. Why can't we bring stroke unit equivalent care to rural Alberta? We can. Yes, we can, as our departing president would say, of our neighbor to the south. So I'm going to turn things back to Francois to take us home and talk about one of those major things that's organization-wise, but which Strategic Clinical Networks are a major partner in.
So I want to touch on our most recent, really what I think is a great opportunity is how can we improve clinical appropriateness and really eliminate wasteless in the system. And, try to define what clinical appropriateness is about and, really about, either underuse, could be misuse or overuse of the system. And one of the biggest challenges that we have as healthcare providers is, more is not necessarily better. We know that, more testing, more procedures doesn't necessarily lead to the best outcomes. And it's the appropriate part that what's the middle ground. And we know there's a huge opportunity cost in terms of, using dollars that don't necessarily offer the best outcome and the best quality and redirect those dollars where they're better used. So, however, to do this, there's 100,000 clinical encounters between users of the system, patients and others, and healthcare workers in this province. So this is where the opportunity is. The opportunity is with each of these encounters to improve and to make sure that we use the best evidence, the most appropriate care possible. It's through your clinical evaluation, it's through the investigations that you use, whether it's lab, whether it's DI, it's where the treatments that we use, whether it's through drugs or of other very, expensive technologies that we use. So this is where we need to target our efforts, and this is where the opportunity really is. We know that we need to have different conversations with our clinicians. If you approach clinicians, talk about quality, they're all over it. Clinicians are very, very passionate about quality. However, if you talk to them about cost, they become afraid. They become afraid of that their access for their patients will be impacted. They're afraid that they won't have the resources to care for their patients. So we need to start having a different conversation. We need to talk about value. I think now we're ready, and our clinicians, and I think folks in the AMA and our clinicians at large understand that if we pay for things that doesn't offer value or the best outcome, that they're not necessarily wasted, but they're dollars that we could use better elsewhere. And I think they're ready to have this conversation. The other level of conversations we need to have is, okay, you are an independent contractor, you're a clinician, you work within the facilities, you come and see and evaluate patients. We need to start having a discussion about, okay, what are actually your outcomes? How are your outcomes compared to your peers? How are your outcomes compared to other national benchmarks? What's your contribution to the healthcare team? So we know that teams is going to be the solution of the future. We're already in that journey, but we need clinicians to be involved in those teams. We also need our clinicians to be involved not only in direct patient care and caring for their patient, but in the health system at large. And we know that they can offer tremendous value. So I love this slide. This is from my colleagues at the Foothills Hospital. And this is showing physician variation in ordering a CT scan for a minor traumatic brain injury in 2014 and 15. So I don't know what the right variation is. You've got to accept some variation in how people practice clinically, but it's certainly not between 20% and 80%. And, and I'm focusing on the Foothills. I see Brian there. It's the same graph at the University Hospital, by the way, so don't get any other impressions. I just wanted to show one example. But this is and Andreas touched on this as well. We've got to address this issue where our clinicians are having tremendous variation, and while some variation is acceptable, that tells me that here we're not using a particular very expensive test and in the best interest of patient care, first of all, because there is some potential, there is potential complications with using radiation, and not necessarily with the highest value in mind. And so we need to get to this. We need to be able to develop some kind of buy-in within a physician community in terms of setting not only the changes of behavior, but the accountability in terms of using the best evidence. So we think that in developing clinical appropriateness and focusing on our clinicians, we need to have some key principles. It has to be co-creative and it has to be collaborative. We have to do this in collaboration with our physicians. This cannot be a top-down approach, and we know we have good example where that has worked. And we have to find some way of not only giving them their data. So audit feedback is great. Hey, I've got audit feedback with the CT scan. We actually provide that to our emergency physicians. But we need more than that. You need some kind of plan of action after the audit feedback to change the behavior, change the practice, and ensure that actually it's changed. And that's got to be done, cannot be done from a top-down approach. It's got to be done by buy-in from the physician groups. We need a process that looks at, what is the existing practice, where are the most cost-effective initiatives, what is the gap in care? What are the recommendations for best practice? And how can we actually change somebody's best practice? So a key is the change management methodology. We're great at doing pilots. We're great at doing things that last 2-3 years for enacting change. We've got to be a lot better in terms of that cycle. We got to put the knowledge to action cycle in an accelerated fashion. And, we don't have 2-3 years now to implement a pathway and to enact change. We probably want to do this in 6 months. So this is going to take quite a considerable amount of work and considerable amount of thought in how we do this, and really set clarity in terms of roles and responsibilities at all levels. I'll finish with this slide. Here's the opportunity. In AHS, 16% of our budget is spent in diagnostic services, drugs, so lab, DI, and drugs, 16%. There's 11 SCNs to help reduce variation in practice. We have a quality a portfolio that can support that as well. If in finding 15% efficiency through appropriateness, so reducing variation, principally through reducing variation, ensuring that people follow best evidence, the return on investment from a financial perspective is about $340 million. It's not small change, and it's also better quality for patients. So that's the end of our presentation. John, I think we're 2 minutes before the break, so we're on time.